Hello everyone, my name is Dr. Amanda Karmas. I am a speech pathologist and postdoctoral research fellow with Cerebral Palsy Alliance in Sydney, Australia. And I will be talking all about eating and drinking and swallowing for children with cerebral palsy. I was very, very fortunate to come to Bangladesh last month and spend some time at CSF Global with Ishrat, Mahmood, and a few people that are on this call, which was a wonderful experience. And so a lot of the learnings that we will go through today, and pretty much all of the photos that we will go through today, will be from our experience there as well. So the principles that we'll go through were ones that I had researched in my PhD. And the great thing about these principles, and that we'll see, is that the principles themselves can be applied to various different settings. And we put that into practice when we were in Bangladesh, and you'll see some of the creative ways that we did that with what resources we had available to us. So the idea is that the principles are what I want you to be able to take away and then adapt to whatever setting and resources that you or the families that you work with have. Okay. We'll get started. So firstly, we'll start with all the things that can go wrong, and then we'll come through at the end with a hero with how we can try and help. So dysphagia is the term that we use to describe difficulty eating, drinking and swallowing. It's the medical term that we use. It's also called oropharyngeal dysphagia, but today I'll be talking about difficulty eating, drinking and swallowing and use the word dysphagia. So the first thing that I want you all to do is, where are we? Tilt your head back all the way and try and swallow. It's a very uncomfortable feeling. I want you all to have a go at experiencing that, because this is what it feels like for many people who have dysphagia. And we swallow 900 times a day. So imagine that feeling of trying to tip your head back and swallow when your body is telling you no, it's not safe to do so. Trying to do that 900 times a day, it's not a pleasant experience for many people with dysphagia. A successful and safe swallow requires the perfect coordination and precise coordination of 31 pairs of muscles. So altogether, that's 62 if your math is any good, and 6 cranial nerves. So there's lots of coordination of muscles, and at exactly the right time, in exactly the right way. So if you have cerebral palsy and you have trouble coordinating your muscles, then it's only natural that these 31 pairs of muscles and 6 cranial nerves will also have difficulty. And that means we have difficulty eating, drinking and swallowing for many kids with CP. So we just did this one. And you can see for children with cerebral palsy, there is a very high prevalence of dysphagia. So not just in the more mild GMFCS levels 1 and 2. Not just in GMFCS 4 to 5, who are the most severe. We do see it in those who have milder cerebral palsy, even those that can walk independently with no difficulty. 31% of them also have dysphagia. And it persists throughout the lifespan. So you'll see that similar numbers of adults also present with dysphagia all the way through to the milder ranges. So there are many risks that come along with dysphagia. Malnourishment is one of those. So we see about 30% of children with CP, this is in Australia, are below the 3rd percentile for their weight. In low middle income countries, this is very likely to be higher, where food scarcity and availability to safe foods is more difficult to get. And growth faltering. is also present. So that can impact their development, their neurological function, and their immunity even more. So they're at very high risk of cognitive and greater developmental disabilities and infection, much more so than the broader population of children with cerebral palsy. And that can further impair musculoskeletal development as well. And then we have a lot of stress that comes with meal times. You can imagine as a parent, the main job that you have, particularly with babies, is to nourish your child. And if you can't do that safely, and it's almost like you are drowning your child every time you try and feed them, or they're not eating enough to grow, or they're not eating enough to develop and to have a strong immune system, and there is a battle of refusal and you wanting them to eat, meal times can be extremely stressful for both the child and the family and the entire wider community as well. And as a person who has difficulty eating and drinking, a big part of our social networks within multiple cultures is eating with our loved ones, sharing food, cooking food. And if you can't do that safely, or it's not a pleasant experience for you, or it's a messy experience, or it takes you much longer than everybody else, then that can lead to social withdrawal and exclusion as well. And if it takes extra work to feed your child who has cerebral palsy and dysphagia, then you likely want to do that at a separate time to when you're trying to eat and drink yourself. So that further excludes these children, and as they become adults, from that family mealtime or social mealtime experience. And then we have what's called aspiration pneumonia. So if food and drink goes down the wrong way because they have dysphagia, then that can go into their lungs. And when it goes into their lungs, that's called aspiration. And if bacteria goes along with that food or drink that goes into their lungs, or if bacteria goes along with the saliva that then goes into their lungs, and they have a compromised immune system, then that can lead to what we call aspiration pneumonia or a chest infection. And this is the second most common cause of death in cerebral palsy. So the risks for dysphagia are very, very high. There are many systems that can influence the risk of dysphagia or cause dysphagia with cerebral palsy, and that is their neurological system. So if the brain is not working the way that it would, then coordinating our muscles and our cranial nerves is also impacted. So there are several conditions, neurological conditions that can lead to dysphagia. Then if you have a compromised respiratory system, that can also impact. You can imagine you need to be able to breathe to be able to function. And all of our anatomy, our breathing anatomy and our eating anatomy are all so close together. And you'll see some videos later on where the entrance to the airway and the entrance to our esophagus and stomach are right next to each other. And we have to close off our airway in order to be able to swallow. But if our airway doesn't close off when we swallow, that's when we get aspiration, when food or drink enters those airways. And so if we're not able to breathe, our body will always prioritize getting oxygen over anything else. So if we have food in our throats, and then our brain kicks in and says, no, we are short on oxygen, we need oxygen right at this moment, because we have respiratory distress syndrome or other respiratory condition, then our body will breathe. And that food that is in our throat or at the top of our airways may very well go along with it into our lungs. So coordination of our respiratory system is very important and can increase the risk if we have difficulty there. Our gastrointestinal system. So if we have reflux or food coming back up, that can then tip over into our airways, causing aspiration pneumonia as well. Or if we have reflux and we learn that every time we eat, we experience discomfort, then our interest in eating and our desire to eat can also go down. If we have any motility or digestive issues, constipation, diarrhea, then again, our body learns I don't want to eat because our bodies, because when we eat, it leads to further discomfort. Also, if we're backed up and constipated, then our appetite and desire to eat also goes down. If we have a cardiac condition, that can lead to fatigue because we're not getting enough oxygen pumping through our system. And if we're fatiguing, particularly fatiguing during a mealtime, then that can increase the safety risks that come when we're eating and drinking. Our ability to coordinate our muscles for the entire duration of a feed can also go down. So we see those risks increasing as the meal goes on. And if we have any structural conditions that are associated particularly with our mouth, our lips, our face, or our respiratory system or our digestive system, then that can lead to dysphagia or increase our risk as well. And experience. So a lot of the children that we see with cerebral palsy have had terrible noxious stimulation to their face. Bad experiences from when they were younger in the hospital with tubes, eye tests, intubation, nasogastric tubes coming in and out, oxygen support. Anytime anybody comes close to their face, it's a negative and painful experience. And they learn and hold on to this trauma. So that when we start to give them food, or we're breastfeeding or bottle feeding, that can trigger some of those traumatic memories and their body can shut down again. Their desire to want to eat and their fear of eating can kick in. They go into fight or flight mode. And if we're going into fight or flight mode, our body is saying the last thing that you want to do when something is trying to attack you, when there's a lion trying to kill you, is to feel hunger. Our body instinctively shuts off our hunger cues when we are stressed, when we are anxious, when we think that something might hurt or put us at risk. And so many of these children that we're seeing who have dysphagia have very poor appetite regulation or awareness. And then not wanting to eat, that leads to feeding aversions and more increased stress. So it's this increasing cycle. So these are some signs to look out for of dysphagia. Some are very obvious, some of them not so much. We need to look out for all of them because some of those obvious cues, particularly if you have a neurological condition like cerebral palsy, you might not see some of those more obvious or overt cues. So coughing is a big one, and that is our body trying to protect our airways. Like I said, we might not always see coughing. And even if we do see coughing, it doesn't necessarily mean that that cough is strong, effective, and fast enough or timely enough to be able to protect our airways properly. So sometimes we say, oh, good cough, that was a good cough. But we don't know if it was a good cough without being able to see it under video fluoroscopy or X-ray video. So wet voice is another one, gurgliness, rattly breathing, wheezing, increased work of breath. You might notice a tracheal tug, pulling like this. If they don't have many clothes on or a shirt, you might see some intercostal recessions between their ribs, or head bobbing like this, trying to get more air into them. These are all signs that they're having trouble with breathing. And we know that if you have any respiratory issues, that puts your risk of dysphagia and aspiration higher. Difficulty sucking or forming a seal with a bottle, a cup, a spoon. Any food or drink left over in their mouth after the mealtime is another sign that they're not efficiently using their muscles. And then there's a risk that any of that residue in their mouth can accidentally go down the wrong way after a meal when they're moving or walking after the meal or moving around after the meal, or if we lie them flat after the meal. Difficulty biting or chewing is another sign of dysphagia. Losing food or drink from their mouth. So if they spill, that also applies for drooling. If you notice that a child is drooling, then they very likely have dysphagia. Glassy eyes or watery eyes is another sign of stress or distress. Colour change in their face, so it could be flushed cheeks, it could be perioral or periocular cyanosis where they start to turn blue. It can be quite subtle, so things to look out for. Fatigue. So if you notice they do pretty well at the start of the meal, but then as the meal progresses, they're not doing so well. They're starting to tire. Meal times are going much slower. That's a sign that they're at increased risk and having difficulties. Vomiting or discomfort, pulling away, any feeding aversions, stretching as well is another sign of reflux that might lead to the dysphagia. Gagging, so not gagging every now and then, particularly for young babies, but if they're doing repeated gagging, that's a sign that they're having difficulty controlling those food that's in their mouth. If they have constipation, a big one is recurrent chest infections and fever. So often we will see doctors prescribing antibiotics repeatedly for some children, and this can be a bit of a tweak, particularly if they're not doing a chest x-ray. Can be a sign for us, a red flag to say, okay, perhaps this child has something else going on. Perhaps they're aspirating and that's what's causing them to get sick all the time. This is especially true if they're getting sick and nobody else in their family is getting sick. So that's a sign that it's not a viral infection that they get there. That's a contagious infection, but there's something within them that is causing that. And that, again, is that bacteria that's going into their lungs. Weight loss, poor growth, and refusal or avoidance. So as I mentioned, aspiration might be silent. In fact, particularly if you have a neurological condition, because your reflexes, like your cough reflex and your airway protective reflexes, might not be working as well, along with all of the other reflexes in your body. And 95% of babies under 1 who have cerebral palsy and dysphagia will aspirate silently. That's a huge number, so we need to really be mindful that we might not see any clear signs. So look out for all of those more subtle ones. Okay, if you have a drink with you or some food, great. If you don't, I'll give you a second to go grab some because I want you to try something. Actually, yes, I've got some food here. Okay, so I want you to try and take some food. I've got a nut here. And I want you to try and take a bite of it and chew it and swallow it, but don't use your lips. Okay, so I'm going to try it now and I want you to try it as well.
Everyone feel free to join Amanda and
please do.
Turn on the video.
Otherwise I'll look like a fool here.
No, Amanda, thank you so much for demonstrating. Like, yeah, others, please feel free to join.
Okay.
Well, honey, you're not trying.
Thank you. It's very difficult. You'll see there, I closed my lips a couple of times and I wasn't allowed to. It's very the chewing is okay. If you have a lot of food in your mouth, you can you might lose some of it from the front of your mouth. You're not able to lose your lips well. But trying to swallow when your lips are open is very, very difficult. So any children who have poor control or tone in their mouth, if they're not able to close their lips or if they're not able to close their jaw, will find it particularly difficult and uncomfortable to swallow. Okay, now we're going to try that again. And this time, when you do it, you can use your lips, but you might have noticed when I was chewing earlier, my tongue was moving from side to side. And that's what we do. We bite food with our front teeth, and then we use our tongue to move it to our side teeth where we do all of our chewing. But for this exercise, I want you to try, take your food and chew it, but don't do that side to side movement with your tongue. I want you to only do forward and backwards movement and see how that feels. So I'm going to try. I'd like you to try as well. It's impossible. I can't move this food to the side to chew. I'm going to move it anyway. And I'm going to go back to just moving my tongue side forward and back. Takes a very long time and it's very, very difficult to do. You might also see when I'm chewing, when I'm just doing this forward and back movement with my tongue, is my jaw is just going up and down. But normally when we chew, our jaw goes round and round and round. If you picture a camel or a cow or a goat chewing, you'll see these round rotational movements with their jaw. That's what we do as well. And that's our tongue moving sideways to try and control that food. So if you see a person who's only doing up and down movements with their jaw, that's a clue to you that they're probably not moving their tongue side to side. And that's part of a reflex. So if you're doing any oral motor assessments, you can test for this. If you take your finger and you put it, stroke the side of their tongue, they should move their tongue to that side. And then you try the other side, you stroke your finger on the edge of their tongue, and they should move their tongue to that side as well. If they're not doing that, then that's a sign that there's a neurological cause for them not being able to move their tongue side to side, and we can start trying to teach them how to do that, build that skill over time, or use compensations, and we'll go through some of those strategies later. I'll probably end up coughing for the next 20 minutes because I haven't been able to eat this nut very efficiently. Luckily, my airway protection reflexes are pretty good, I think. Okay, so now we're going to do another exercise with a drink. So the same thing that we did before when we took a bite of our food without using our lips, we're going to try and do that with a drink. So if you have a drink there, try and give it a go. Try and clean any residue of that food left over in your mouth because I don't want anybody aspirating or choking on me. Okay, I'm going to try and drink with no lips. Again, I lost a lot from the front of my mouth. It went all over me. And it was, again, very difficult to be able to swallow. I had to really overuse and be quite forceful with the tongue up against the roof of my mouth to be able to try and coordinate that bolus. So bolus is essentially the ball of food or drink that we make in the center of our mouth. And that's where we want, how we want our food to be or a drink to be inside our mouth. We don't want it all spread around. We want it in one cohesive ball or bolus so that it's easy to swallow. So it's very difficult to do that with a drink without using your lips. Now this time, I want us to take another drink, but I want you to lift your feet off the ground. I'm not sure if you can see my feet here. I'm going to try and lift them up. Okay, I want you to do the same, and we're going to have a drink with our feet off the ground. Okay, so that was a bit easier to do from an oral motor coordination, but I don't know if you felt that you really had to concentrate and think about not leaning to the side, not falling over, not how you have to control those muscles in your trunk and in your hips. It takes a lot of extra effort and coordination. And because we're putting all of our energy and effort into trying to stay upright, the ability to control and use the muscles and focus on trying to control the muscles in our mouth and in our throat is less because we're splitting that cognitive load and that muscular control load between our whole body now. So we need a really stable base. We need our feet to be flat on the ground. We need our hips to be all the way back in our chair. And in order to be able to have a stable base for our trunk as well, so that we can focus all of our energy in our head and our neck. Okay, last activity before I let you all off the hook and relax. I want you to take a drink of water with your head tipped back this time. Okay, so like this. Nice experience. Very difficult. I can see Farhad doing it. Good job.
Yeah, I tried it and I had a big cough, Amanda.
Yeah.
Not possible. Yeah.
Actually, I am practicing with you.
I don't think anybody can practice to improve this, Farhan. It's our body just does not want to do it. And the reason that our body is rejecting this is because if you think about this position, when else do we see it? We see this when we're doing CPR. Yeah. And we do this when we're doing CPR is because we want an open airway. We want to be able to give our respiratory support to somebody who needs it with their head tipped back. And so when we tip our head back like this, our airway is beautifully open. It's great for breathing, not so great for swallowing because it stretches the entrance to our airways, and our epiglottis, which you'll see very shortly, isn't long enough to be able to close that space anymore. It doesn't completely close over because it's stretched out. So it goes straight into our lungs. Luckily, we all hopefully have a very strong neurological and cough system that we're able to protect ourselves timely, and strong, that our cough is strong enough to be able to eject any drink that's gone into our airways. So keep all of these aspects in mind. If you see that someone's not using their lips, if you see that somebody is sitting with their feet off the ground, or they're slumping to the side, or they're having trouble controlling their head, these are all signs that they're going to have even more difficulty. So positioning is really very, very important. We'll go through some strategies for how to help with lip seal and positioning later on too. Okay. So here's a video. I don't think, no, this is not going to work. I'm just going to have to get out of this for a second and find our video so I can show it to you. Okay, so this is a normal swallow. Can you see this?
Yes.
So great. I'll just orientate you. So this is a person from the side. So you have their nose here, their lips, their chin, their throat, and this is inside their mouth. So these white things are teeth. This big red thing is their tongue, and then you have the roof of their mouth here. So they're having a drink of water, and it goes through their mouth and down through their esophagus to their stomach. This is their airway here. So that's their voice box or their trachea. And their vocal cords are closing. And this little cartilage here, the epiglottis, closes over to stop that drink going into their airways and their lungs. So like we were doing just then with our head tipped back, this space here stretches and is even longer. So the ability for this epiglottis to close over will be compromised with their head tilted back. So I'll show you another video now of another normal swallow, but this time is with solids. Hang on. How is this? Okay, so this is with solids. So there are a couple of chews. And you'll notice that with solids that the speed that the food is moving through the mouth and the throat is not as fast as fluids. So solids tend to move more slowly. So keep this in mind if you have an uncoordinated swallow. Liquids move very quickly. It doesn't give you very much time to then try and protect your airways. So we'll go through thickening fluids later on, but that might be an option for somebody who's having difficulty closing their airways. Okay. So I'm going to show you another video of aspiration after the swallow. No, I'm going to show you aspiration during the swallow. Okay, so this, I'll pause it before we start so I can orientate you. So it's the same footage, but this is a footage of a video fluoroscopy or modified barium swallow. Essentially, it's an X-ray video of somebody eating and drinking. You might have access to this in the settings that you're at. You might not. I would expect that most people in LMRCs would not. But this is just an example of one of the assessments that we sometimes use for people who have dysphagia. So it's the same orientation. You can't see the whole face here because there's radiation exposure with this, so we try and minimize how much of the body is exposed to the radiation, so you can't see everything. But the nose would be here, the mouth is here, that's the chin, that's the neck, and this grey mark here is that epiglottis, and you'll see this is the airway and this is the esophagus that goes to the stomach. So this is a person with a drink, and you'll see that a lot of that drink has gone down through the airways. There was no cough, gone straight down to their lungs. Some did go down to their esophagus, but there is quite a bit of fluid that's gone down into their lungs. And we can see this because we mix the fluid with contrast called barium or omnipaque. But that airway, so you'll see here, where is it? That epiglottis here didn't close over completely, and some of that fluid then trickled into their airway. So that is a classic example of aspiration. If there's any bacteria that goes along with it, then that's very likely to cause aspiration pneumonia. Okay. All right, so this is aspiration during the swallow. Oh, is this the same video? 1 second. No, I think this is the same video. Okay, so here's the second video. This is with food, aspiration before the swallow. So you can see that person trying to chew, now they're trying to cough. They're trying to chew, control the food. They don't have great control. The food's gone down, their airway here is still fully open. That epiglottis is not closed over at all. And a big piece of food went into their airways. This can be quite distressing to watch. That person is coughing. So if you were clinically seeing them, you'd say, oh, they're coughing. It's a good cough. It's not a good cough here because their cough is not quick enough and it's certainly not strong enough to be able to remove that food that's gone straight to their lungs. So these can be quite distressing. If you'd like to talk to me about any of those later on, I'm here to have a chat. But I would imagine with those last two that even if the cough, even if they didn't cough, that we would see some more of those subtle cues that they are having difficulty. Okay. So these are some of those signs. We talked about some of them already, but these are some signs that you can talk to families about. So are you stressed during meals? If mealtimes are stressful, there is more than likely a reason why, and it's very likely to be dysphagia or some kind of digestive esse or gastrointestinal issue that's going on. Are you concerned about weight or growth? Does your child have any trouble breathing during or after meals? So often we see, I'll see a child in my clinic and I'll say, oh, that's interesting, they coughed. And the parent will say, oh, it's okay, they're just a little bit sick at the moment. And I'll say, sure, they might be sick. But before they started eating and drinking in the 15 minutes that we were here just having a chat or playing, your child didn't cough. And I'm always looking out for that. I'm looking out for what is changing from their baseline before they start eating and drinking, before we even present food to them, to what changes to when we present food and what happens when they start to eat or drink. So if they're not coughing before the food comes out, but then the food starts to come out, they start to produce more saliva because they smell and they see the food and their body kicks in to know that they're starting to prepare to digest that food with extra saliva. And then they start drooling more, or then they start coughing. That's a sign that they're not managing that excess saliva that is being produced. If they're not coughing before the meal, or they're not having any trouble breathing before the meal, but then you notice some tracheal tug or head bobbing, or that any colour change in their face during the meal, or increased drooling, that's all a sign that there's something else going on. Have you had any recurrent chest infections or pneumonias? Or have you had lots of instances of antibiotics prescribed that maybe they thought was just a cold? Or sometimes even if they have been diagnosed with asthma, that can also actually not be asthma, but be chronic aspiration. So something else to keep in mind. Do you cough, gag, or choke when you're eating or drinking, or does your child do that? Do meal times take longer than half an hour? If they're taking longer than half an hour, there's generally some kind of efficiency issue or fatigue issue that's happening. Do you have symptoms of reflux, heartburn, or vomiting? Or does your child, and are they taking any reflux medications, or are they using thickener for their drinks? Or are they constipated or have dark urine with a strong odour? If they're wearing nappies, asking them how many nappies are within 24 hours, how many times are you changing their nappies? So we'd like to see 4 or 5 medium to heavy wet nappies a day, and we'd like to see that they're opening their bowels every 1 or 2 days. If they're not, then that's a sign that they're not getting enough hydration or not getting enough nutrition. So how can we help? So we talked about everything that can go wrong, but now we'll talk about things that we can do to try and help. So these are some developmental signs of normal eating and drinking. So the things that we like to see at which time point. So normally around 4 to 6 months, babies are breast and bottle fed. They're managing that quite well. At around 4 months, we often see lots of feeding difficulties pop up that seemingly weren't there before. And that's because under 4 months of age, the suckling reflex is automatic. It's a reflex. Babies don't have any active control over it. If they don't have to actively do anything to make it happen. After about 4 to 6 months, this suckling reflex becomes integrated. So that automatic action of suckling that they had before is gone, and it's now fully within their volitional control. And so if they are having trouble, this is when we'll start to see it, because it's not automatic anymore. So if they don't want to do it because they're experiencing reflux or discomfort or digestive or gastrointestinal issues, they can start to refuse at this point. If they're having trouble coordinating the suck, swallow, breath pattern that we need to happen every second of every minute of the feed, it can be very difficult for a child to maintain if they don't have that help from that central pattern generator. Around 6 months is when we look to start solids. And what we noticed with a lot of the children that we saw in Bangladesh was that there were many children much, much older than 6 months who were still on fluids. Some children who were 4 or 5 years old and they were only still having milk. So it's very important in this window between 6 to 12 months, closer to 6, that we are starting to expose children to purees and soft family foods. The reason that we do that is because this window is a perfect opportunity for learning when nutrition isn't so much of an issue. So we don't need to worry about how much they're having solids-wise, if it's only a little taste here and there, but they need to be able to practice having those foods and learning how to chew while they still have some of those early reflexes available to them. The other thing is, but before 12 months, is we need to be able to expose children to allergens, so common allergens like nuts and seafoods, so that their bodies, a lot of the research shows if you are exposing children to common allergens before 12 months, their likelihood of developing an allergy to some of these foods is much less. So if children don't get exposed to these common allergens before 12 months, then they're much more likely to have anaphylaxis or an allergy to those foods as they get older. Between 9 to 12 months, we start to introduce cup drinking and straw drinking. And at 12 months to 18 months, they're starting to be much more independent. So they're starting to hold utensils like spoons or forks or more foods and bringing those to their mouth more efficiently. And around 18 to 24 months, 2 years old, that's when children can pretty much eat the same foods as most of their family. Some of them might still need to be modified if they're choking risks, like nuts. You don't want to serve whole nuts to children before they're 5. Things like popcorn, hard lollies, anything that is small and round and hard or very sticky can be a choking hazard. So we don't want to offer those to children until they're 2. The size of the food that we want to offer should be the size of 2 adult fingers. So that will reduce their choking risk. The bigger the food, the less likely they are to choke on it. Okay, some signs to look out for that children are having stress or at risk of aspiration or are uncomfortable during their feed. So change in breathing, we spoke about already. If they're turning their head, extending or pulling away, if they're grimacing like this, if they're raising their eyebrows, that's again a sign that they're trying to get some more air or trying to get away. Loss of tone, so if they all of a sudden become quite fatigued or slumped, that's a sign that their body is shutting down, saying this is too hard, I need to shut down, it's my only way out of this environment or experience. If they have any increased work of breathing, so you might notice their nostrils flaring or blanching, the head bobbing that we talked about, tracheal tug, splayed fingers, or we call that stop sign. So if you ever see a child doing this, that's a sign that they're stressed and having difficulty with their breathing. They're starting to lose more from their mouth. Their body is saying, I can't manage this in their mouth, so I'm going to get rid of it or spit it out. Vomiting. And some of these clinical signs we've spoken about: coughing, wet voice, gurgly, rattly wheezing, increased stridor, repeated gagging, flushed cheeks, widening eyes is another one that we haven't talked about, or starting to tear up if you notice tears dripping from their eyes. Okay, so this is an example of a child showing some stress cues during the feeds. He's turning his head, trying to pull away, but his mum keeps following him with the bottle. So I encourage everyone just to keep their hand in the middle when you're serving food or drink to them or holding a bottle. That allows them to get away, to take a break. He's starting to push back again, extending. Don't know if you can see him in the corner of his eyes starting to tear up. His eyebrows are raising. Again, trying to extend and turn away. There's some teary eyes there. If you have access to a stethoscope, a small infant stethoscope, that can be really helpful. This is called cervical auscultation. You need training to be able to do it. But if you don't have access to the training, it is helpful just to listen to what breathing sounds sound like before food comes out, and then during, when they're actually during the feed. That helps you to detect some of that gurgliness or wet breathing that you didn't hear earlier. He's trying to push the bottle out from his mouth, but his mum's keeping it there. So that's quite a stressful feed for this little one. Okay, so these are the main 3 categories of intervention. So compensations, skill training, and direct intervention. Compensations are things that we can implement straight away that immediately improve safety and reduce aspiration risk. They also improve the functional skills of the child that's eating. It makes mealtimes more efficient. It simplifies the task, and generally it uses some sort of alternative equipment, or you've modified the food or the way that you are feeding or supporting this person. Then we have skill training that's broken down into indirect and direct interventions. So skill training are interventions that try to improve skills. So we have indirect intervention. They use non-food items as a stimulus. So things like silicone tubes, other utensils or spoons, or non-food items like whistles or bubbles or blowing, any of those foods that try and improve strength, but it doesn't actually use food. Also stretches, vibration, massage, any oral motor exercises like getting a child to say ba 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 ba, ma 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 ma, or doing things to them, all fall under the indirect category. And then we have direct intervention, which also aims to improve skills and strength and coordination, but actually uses food items to try and do them. And so when we do them, when we do intervention, we start with compensations if we need to, and only if we need to. And then we can start to reduce compensations as quickly and as soon as we can, because we don't want children to be reliant on compensations. If they never are able to practice the skill or practice the task as close in its full form, or as close to its full complete task as possible, task-directed training is what we call it, then they will never be able to, or their likelihood of being able to learn that whole skill, that whole task without the interventions is even less. So if we are here helping a child to chew every time that they have something to eat, the likelihood that they'll develop and learn to chew without us doing it with them is very low. If we thicken their drinks or puree all of their food and never give them the opportunity to have thin fluids, or never give them the opportunity to eat foods that need chewing, the likelihood that they will be able to learn to chew foods is very low. But if we give them opportunity safely in short amounts to practice drinking thin drinks or to practice chewing food, then they get that opportunity. If you practice something, you get better at that thing. If you practice passive stretching, where somebody takes their jaw and does this for them, or massages their cheeks or massages their lips, there's a very low likelihood that that will transfer over to a mealtime and improve their mealtime skills, particularly if somebody else is doing it for them. And the reason that if it is a passive task, they're not generating any of those messages from their brain to those muscles. And that's how we develop, that's neuroplasticity, that's how we develop those pathways. If those pathways are not getting used, they're not going to develop. So passive activities or passive stretches or passive massage is not going to improve their skill. It's not going to improve the brain pathways and connections that we need the child to learn. Active oral motor exercises that don't use food, be it chewy tubes or practicing blowing to try and get their lip closure, uses a different part of their brain than it does while they're eating and drinking. Trying to practice speech sounds like pa, 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 ba, ba, ba also uses the left brain, their speech centers. It doesn't use the motor parts of their brain for eating and drinking. So you're not stimulating those neural pathways and brain connections that we need for eating and drinking. So yes, you might see an improvement in strength during those exercises, but the likelihood that they will generalize over to a mealtime is very low. So I would always encourage you to use direct interventions where you can and where it is safe to do so. This is the biggest takeaway that I want you to learn from today is yes, compensations are necessary sometimes, but don't stay there. Move as quickly as you can away from using them or reduce them or offer them just from time to time or every few mouthfuls or every few sips of food. Not consistently, so long as they're remaining safe. When you've got them safe and you can start to challenge their skills a little bit, reduce the compensations and start challenging them using harder foods or fluids so you can give them opportunity to practice the real whole task and improve that skill. Okay, so we're going to talk about some compensations. So seating and positioning is the biggest one, the first one that we use, and one that's most likely to be used for a prolonged period of time. So if you're bottle or breastfeeding, we always want ears above shoulders. The reason that we want ears above shoulders is because, or a couple of reasons, because gravity, that angle, can help to keep the food down and move the food down to their stomach. Also for babies, if they're lying flat on their back, then they are at more of a chance that the fluid or the milk will go into their eustachian tubes in their ears and they can develop an ear infection. So ears always above their shoulders. Also, even if you're an older child and you're lying flat on your back for eating and drinking, gravity can be too strong here. If you imagine lying down on your back in bed trying to drink, you'll lose a lot of drink from your mouth firstly, but then that fluid that we saw that already moves faster than food will move even faster because gravity is pulling it down. So upright positioning as high and upright as you can is always best. This is an example of what we call elevated side lying for babies, where the bottom is up against the parent's chest. Their hips are in a flexed 90-degree position, their knees are in a 90-degree position, and their head and back are nice and straight and their head is elevated. And you'll also notice the bottle is on the side here, so the teat of the bottle is about half full. So the flow of the milk is going to be much slower and better controlled here than it would be if the child was in a Madonna hold or a Madonna position, that typical cradle position for breastfeeding or bottle feeding. And then timing. So the slower flow teat, the easier it is. So often we think, oh, we'll give a baby a faster flow teat so they don't have to work as hard trying to suck from the bottle. But actually what they have to do in that case is they have to work harder at coordinating their suck, swallow and breath pattern over and over and over again. So they tend to get more tired and more fatigued when that flow is faster for them. So slower flow rate, even though it seems to be counterintuitive, slower flow rate for bottles is easier for them. The amount of effort that they have to use to extract fluid from the bottle is likely to be much less effort for them than it is trying to coordinate suck, swallow, breath, suck, swallow, breath, suck, swallow, breath over and over and over again when that milk continues to come out of the teat. Shorter, more frequent feeds can also help for children who have reflux or fatigue during their meals. So there's some strategies that you can use. This is what the side lying looks like from above. Okay, so this 90-90-90 positioning is what we're trying to aim for ideally. So we want their hips to be flexed, just like building a house. We want this stable foundation. If a stable foundation in your house, then the top stories of the house won't collapse. This is the same with eating and drinking. So we practice trying to drink with our feet off the floor. We saw how difficult it was. We want the bottom to be all the way back, the knees 90 degrees, the ankles 90 degrees, the hips 90 degrees, and also the head and neck to be at least 90 degrees. If you can get their elbows in 90 degrees with something stable under their elbows to support them, that's even better. So a tray or a table can be really useful for extra support. So these are some examples of what we did when we were in Bangladesh. So sometimes you'll need a bit of an angle here to stop the head from falling forward. What we tend to do is push their head back. And what does that do? That puts their head and neck in extension in that CPR position, puts them at risk of aspiration. So if it's necessary, and only if it's necessary to tilt a child back, we want their hips to stay in this 90-degree angle. You'll see hips are 90 degrees. This seat stays in 90 degrees, and we've tilted the whole seat back. We haven't done a recline like you see on the aeroplane, where the back of the seat goes back independently of the bottom. This opens that hip angle from 90 degrees to an obtuse angle, which reduces the amount of support that the child has. Also, if this child is in extension, either in their neck or in their hips, in their legs and their feet, it's much harder to do other flexion movements. So chewing, sucking, swallowing, these are all flexion movements where our body comes towards the midline. If the rest of our body is an extension, it's very hard to then get some parts of your body doing flexion movements. So our whole body needs to be in flexion to try and encourage safe chewing and efficient chewing, safe and efficient swallowing, safe and efficient sucking and drinking. So this is another example of what we were able to do in Bangladesh. We had a bucket that we used. Again, this child's hips and knees are 90 degrees or less. He's well supported behind him. He's nice and midline, not leaning to the side. His head is not dropping to the side either. He's very well supported. Another example, we had a child on their mum's lap. You'll see hips in 90 degrees, knees are not quite 90 degrees, but they're at least flexed a little bit. Ankles are flexed, and her neck and chin are also in flexion, her elbows in flexion, mum's holding them there. So this is a great position. It's another position that we were able to try and get here with the child's hips in 90 degrees, and knees close to 90 degrees, feet 90 degrees. So you'll see mum's leg bent here to give a bit of extra support. Her mum's back is nice and well supported behind her so that she's not moving all the time and readjusting her position. Because if she's uncomfortable or gets tired from sitting skewed, or she's uncomfortable, she'll end up changing her position throughout the meal, and that changes the child's positioning as well. So we had mum's leg supported here with a pillow and a basket that we put some heavy bricks in. So mum said she didn't have a corner at home that she could use. So this is us creating a corner. A corner position is great for supporting parents who are holding their child because it's much more stable. So if you don't have a corner in the house that you can use, you can make a corner by using a basket and some bricks. Lots of pillows, lots of cushions. You'll also see here we've got a towel rolled up as a bit of extra neck support for this child. So it's not a perfect one. It looks like it's covering their airway a little bit. We don't want that, but we're trying to create something like a neck pillow that you have when you're on an aeroplane. So that helps to keep stop the head from extending back and stop the head from dropping down too far. So roll up the towel as tightly as you can. So the tighter the towel is rolled up, the more firm and stable that support is. This is another example of positioning. We've got nice flexion at her hips. We've used a prayer mat here. Again, a corner position and some extra pillows and cushions and towels behind this little one. That's a picture of the positioning when she's not there. Again, we're fortunate to have some corner chairs. This is not a child that needed tilting, but she did need some flexion in her knees. So we've lifted that chair up by putting bricks under the chair to give her flexion in her knees and support under her feet. And she's got a tray there so she can rest her elbows for some extra support. This is for a younger child. We've used that same basket and we've created a 90-degree angle here with a cushion behind, cushions under, and then another 90-degree angle with a drop from the cushions to the floor here. This child needed some extra lateral support to the sides of his trunk. So we've rolled up a towel, again, as tight as you can get this towel in a horseshoe shape like this will help to give extra support under their armpits, by the sides of their trunk and under their knees. So their knees go here. So when you've got the towel under there, it helps to increase a little bit more flexion in their knees. So this is the child. We've recreated this in a cardboard box. So this family didn't have access to a basket like this. So we've used a fruit cardboard box you'll see in this picture here. And the grandmother saw us creating this position and we coached her to be able to do the same thing inside a cardboard fruit box. And she said that was feasible for her to be able to get the fruit box and use some towels at home. So you'll see the knees are bent here. He's got some extra support under his feet, under her feet actually. Her hips are nice and in flexion as well. She's nice and upright. She's not reclined. She's in midline and her head is well supported here. And Grandma was looking very proud of herself. We were very proud of her too. And this is an example for an older child. So her bottom is all the way back in this chair. Her hips are flexed. We've got a little tray table that we've used as some foot support. And this chair was nice because it had a table built in that gave her some extra support and stability under her arms and elbows. Okay, so these are some examples of poor positioning. So this child is leaning to the side. So they're trying to control their muscles just to sit upright. So trying to also get them controlling the muscles in their mouth and their throat. And they're not in midline, their head is tilted, the whole body is tilted, is not ideal for eating. This child as well is twisted. We don't want to be twisted when we're eating and drinking because that disrupts all of the esophagus and our airways. And this child is in extension with his neck, that CPR position. This is beautiful, nice flexed position in the knees, the ankles, the hips, got something to rest on. So his elbows are in flexion, his head's nice in flexion as well. Nice foot support in this one. And with this one, the parent or the person that's feeding them is at the same eye line. So that's another thing to keep in mind. When you're at the same eye level as the child, then they're less likely to want to tilt their head up. Or if you're sitting to the side of them, they're going to want to turn their head to the side and will start to twist. So try to be in front of them at eye level with them so they're nice and safe and in midline and flexion too. Okay, so we talked about direct intervention and giving children the opportunity to practice their skills. So these fit with the use it or lose it. So use it or you lose it, use it and improve it. And intensive practice as close to the real task as possible is what you want to try and do. So keep these principles in mind. Again, these are the main takeaways. You need to be able to practice the skill to get better at that skill. If you don't practice that skill, you won't get better at that skill. As intensive as you can practice, the better. So we're trying to practice at least 2-3 times a day, even if it's only just 5 minutes at a time. And you want to practice as close to the real task as possible. So these are some, this is what's called IDSI. So International Dysphagia Dietary Standardization Initiative, IDDSI. So this is how we categorize food or drink. If you Google IDSI, you'll see lots of resources. A lot of them have been translated into multiple different languages on how you can, yes.
Sorry. Didn't mean to interrupt. But like, just was wondering if anyone, because the first part, like the previous part of the session was really, really very informative. If there is anyone has any question before, because to the before we move to the direct intervention. Does anyone has any question that you would like to clarify with Amanda regarding position? Because these are very, very useful and practical lessons.
Yes.
Sorry, Amanda, I didn't mean to interrupt. But
no, please do. That's fine. That's fine.
Okay, Tirada has a question.
Yes, I'm curious about the position in prone. Because on the slide you mentioned that, but can you explain more how to eat in prone, please?
What did I mention eating in prone?
I think it's on the slide, the position with the picture of the sideline drinking
with the
milk.
baby.
Yes. Yeah, and on this slide, that positioning, prone or upright.
Oh, sorry. Yes. Okay. So this is for bottle-fed or breastfed babies. So we want to reduce the risk of aspiration by having them in supine or on their back. So sometimes having the child lying on the parent's chest when the parent is reclined and having them. Let me show you what I mean. Not sure if hopefully you can see the video. So if you're breastfeeding, having the child prone like this with the parent reclined, it can be safer than having them in this position. If that does that make sense? Yeah.
Thank you.
That's okay. So primarily for breastfeeding, hard to feed anybody else in prone. So I'll talk a little bit more about oral hygiene and cleaning mouths and doing that in the prone position. But yes, the prone position is primarily for breastfed babies. Any other questions about positioning?
No, I think.
Or anything else we've gone through? Yeah. Okay, great.
Thanks, Amanda.
Amanda,
Yes.
There's one. Yeah.
do you have a plan to share drooling management?
I'm not going to go through drooling today, but the same principles apply for drooling. The more practice they get with managing their drooling, so it's sometimes closed mouth positions that we can do with external supports, which we'll go through, will help with their motor learning for keeping their mouth closed to then reduce drooling as well. But an increase in drooling is generally a sign of dysphagia because children don't produce more saliva so children with cerebral palsy don't produce more saliva than the general population. The problem is they're either not sensing it in their mouth, so that they're not getting that cue to swallow it, or they have dysphagia and difficulty swallowing, and that's why their saliva is coming out from the front of their mouth. Often what we'll do is we'll put these children in recline or we'll tip their head back. But what that does is it stops the anterior drooling but leads to what we call posterior drooling, where the saliva just trickles down the back of their throat into their pharynx, often with their airway open and them not actively swallowing it. So if they're not actively swallowing their saliva and it's just dripping back down into their pharynx, then their airway will be open and there's a very high risk that their saliva will go down into their airways. So positioning is very important. Having a child in flexion will be your best option.
Okay, my other question is the children whose sucking reflex has not matured yet or cannot perform breastfeeding. What is your suggestion in that case?
Yeah, so with breastfeeding, you can support by doing manual extraction, so that when they talk about the C hold, where the parent tries to manually extract some milk from their breast, can help. A supplemental nursing system can also help, where there's a tube or a line that's in a bottle of either express breast milk or formula that the mother tapes to her breast, and that you have at the corner of the child's mouth when they're breastfeeding, can also help. It can be a little bit fiddly to do, but the supplemental nursing system can help. Or the mother can choose to express her breast milk and offer it from a bottle. And then there's a lot more compensations that you can do with bottle feeding than you can with breastfeeding. Having said that, breastfeeding is often much safer for children who are at risk of aspiration than bottle feeding is. And the reason for that is because if the child needs a break because they're having trouble coordinating their suck-swallow-breath cycle, and they need to catch their breath so that they then don't aspirate, their body doesn't say, hey, I need some oxygen here, I'm going to breathe, even though there is milk flowing. With breastfeeding, as soon as you stop sucking, that breast milk stops coming out, except if you're in the letdown period. So breastfeeding is a much more efficient way for a child to be able to feed because they can pause as they need it. If you test most bottles, you tip them upside down, milk will continue to flow even if nobody's sucking from it. And so when the child wants to have a break and this milk continues to flow, they're not able to have a break. They need to keep swallowing the milk that's coming. So that's just a pointer there that breastfeeding can often be safer.
Thanks,
Okay,
Amanda.
thank you.
That's okay.
There's another question, but maybe we can answer that after we let you continue your session, and then we will at the end have another question answer. Yep.
Yes, sure, that's fine.
Thanks.
I'm going to show you a quick video of the IDSI flow test. So you'll have seen here, just a refresher, that level 0 is thin drinks, so thin fluid, just as we normally would have them. So water is an example of thin fluids. Then we have slightly thick, mildly thick, moderately thick, which is also the same as a liquidized food. We have extremely thick, also known as pureed if it's food. Then we transition over to most of the foods. So mince and moist texture, soft and bite size. And then level 7 is either regular food or easy to chew food. And then on the side here, we have what's called a transitional food. So this is a food that starts off at one consistency and changes to another consistency when it's exposed to pressure or liquid. So things like biscuits that melt in your mouth when you start to mix them with some saliva fall into that transitional category, or chocolate that starts as a solid, that when it heats up with your body temperature in your mouth, it melts. Jelly is another one. When it heats up in your mouth, it turns to a thin fluid. Ice cream, another transitional food. Okay, I'll show you this video. I think I may have forgotten to share my audio. So I'm just going to stop sharing my screen for a second and reshare. I'm sharing my sound. Okay. Okay. And a load. Might not need audio actually. But this is the flow test. So you need a 10-second timer and you need specific syringes. So if you go onto the IDSI website, you'll be able to see the model number of syringes that fit the criteria. So the reason that they have to be certain syringes is that it means that the barrel of the syringe is a certain width, because if it's wider, the fluid will flow faster. So this is a standardized measure for measuring which level these fluids are in, but you need the right syringe to do it. So 10-second timer, you put 10 mils in the syringe, you start the timer, and then you start the timer, and after 10 seconds, you put your finger at the end of the syringe to stop it again. The 10 seconds is up, and then you'll see how much is left over in the syringe. So this has 2 mils left, this has 6 milliliters left, this has 9 milliliters left. And they correspond with 2 milliliters left is a level 1 thickness, so slightly thick. This one that's 6 milliliters left corresponds to level 2, which is mildly thick. Level 9 millimeters corresponds to level 3, which is moderately thick. If we expect, if there's more than 10, there's still 10 and none of the fluid came out, then it's a level 4, extremely thick. With level 3 and 4, you can do a different test. So you can do the fork drip test, where if it flows through the spoon in globules like this, then it's likely to be a level 3. If it sits on top of the fork and doesn't drip through the tines or the prongs on the fork, then it's a level 4 consistency. So there's all of this information on the IDSI website. I really encourage you to check it out so that you can test exactly which level of fluid is safest for the child, and that everybody knows how to test it. We will give parents syringes so they can do the same tests at home, and they can make sure that their child is having the safest version of fluids for them. So remember we were talking about how quickly fluids move through the mouth and into their airways. So what thickened fluids do is gives children more time. It helps to slow things down so that they can prepare their bodies and protect their airways. So there's less likely that fluids might go into their airways. But thicker is not always safer. So sometimes if you're giving child moderately or extremely thick fluids and they have trouble with the strength and coordination in their pharynx, they can have residue of some of those thickened fluids left over in their pharynx. So do keep that in mind, that thicker is not always safer. We did a bunch of experiments with different types of foods that we could use to thicken fluids, because commercial thickeners aren't necessarily available in all countries or all regions. And rice cereal was the best, along with corn flour, particularly if you cook the corn flour, so you mix it into a paste and then mix it into your fluids, and you can test the recipe for how thick they need to be following these IDSI guidelines. Chickpea flour was also effective, and just regular wheat flour was also really effective. So we cooked all of them. We found that cooking them made it much more consistent. Cooked with a little bit of water, and then you thin it as you go. So if you start with thicker and add more fluid to thin it out, it's much better than slowly trying to thicken it up. And these are some examples of the foods. So we'll go through these as well. Always adds. Okay. So level 7, which is regular. Level 6, which is soft and bite-sized. So that's a liquidized. Level 3. Level 4, puree. So you see how they did the spoon, that was called the spoon flick test. earlier, where they flicked it off the spoon and it came off clean. So most of it came off, and it came off in one lump. And then they do the fork test with the puree as well. And it holds its form. It doesn't drip through the prongs or the tines of the fork. So that was mince and moist. There are guidelines to how wide the pieces can be. It's 2 millimeters for an adult or 1 millimeter for a child. Soft and bite-sized, so soft enough to be able to mash with a fork, and no more than 2.5 centimeters in size. And this is level 7, easy to chew. Okay. So please have a look at some of those ITSE resources. They're excellent. Oops. Okay. All right, some other compensation strategies. Using modified cups and utensils. So we talk about cutout cups, which we sometimes have, which allows a parent to be able to support their child to drink with a cutout for their nose. And what the cutout does is it allows us to be able to see how much we are bringing to the edge of the cup. When you are supporting a child to drink, you don't want to pour the drink into their mouth. You want to just bring the liquid right to the edge and get them to do most of the work. Again, they're sending the messages from their brain to their muscles. They're the ones that are actively doing the work. So we bring the liquid to the edge of the cup, and then they put their lips on the edge and they get a little sip of water or drink each time, rather than us pouring it in, which is much harder for them to control and puts them at increased risk of aspiration. If we're trying to teach them how to straw drink, we can use the pipette method. So that's where you put a straw. I don't have a straw, but I'll use a pen to demonstrate. You put a straw in a cup of drink, and then you put your finger on the end of the straw. And what that does, it keeps some of the fluid in the straw, and then you can put the edge of that straw to the child's mouth. And when they bring their lips around the straw, you let go, and then you put your finger back so they get a little sip of water. When their mouth is open, keep your finger on the end of the straw, because again, remember when we were trying to drink with our lips open, it's very hard to do. We want to teach them, you get some when your lips seal around the straw. So the pipette method is a great one for teaching straw drinking. Giving them extra time, so time between mouthfuls. They're likely to move their muscles much more slower than us. They might need extra time to chew, to clear any residue in their mouth. If they have any residue or food or drink left over in their mouth, you can give them some prompts to try and help them swallow them. So either say things like swallow, or, oh, you've got some food left, try and swallow. You can give them a tactile cue, which is a little tap on their chin or a little tap on their mouth to close their lips or jaw so that they can swallow what's left over. You'll see this mum here using some jaw and some external jaw support. So if we create a gun shape with our hand, we put the most of the support and control comes from these fingers that are tucked in and curled under, because they're quite strong. And a lot of our kids' jaws can be very strong as well with extension. So we put our fingers under their chin. This helps to give them extra stability and control to close their jaw. And then we can use our finger to lift up their lip to form a seal on the spoon or the cup. If you can do it, often if we do it from behind, we have better control, but this can help us. All of the support is coming from under their chin, from your fingers that are tucked in, and then some extra lip support under their chin to help create that seal. Remember, compensations are great, but we don't want to be doing this all the time. Otherwise, they won't learn to be able to do it on their own. So as soon as they can do it on their own, you might do a couple of times and then remove your fingers and then remove the rest of your hand. Try and get them to practice to do it on their own. Give them a couple of goes, and then you might want to come back and give them some extra support. So intermittent support is much better. An empty spoon is another thing. So if we sort of trick them into thinking there's more food on the spoon, but put an empty or a clean spoon in their mouth after each mouthful, can help them close their mouth and prompt them to swallow what's left over in their mouth. Sometimes, very, very cautiously, you might use a liquid wash or a sip of drink, but I would only use this for children who have trouble controlling their muscles in their mouth and are not having any trouble with their swallow function. So I would use that very, very cautiously. Placement. So lateral placement. So remember when we did our practice with only moving our tongue forward and backwards, trying to chew the food. And I said we need to use our tongue side to side. Some children can't do it. So we need to try and train them to do that or make it easier for them. So we can or they can put food on the side of their mouth so that we're encouraging their tongue to move to the side. So when there's stimulation on the side, like I said, if you're doing an oral motor assessment and you scrape their tongue, the side of their tongue will move to that side. So when the food is there, they feel that food, their tongue is more likely to go to that side and help them with chewing. So putting food to the side, firm foods are great for that. So stick-shaped foods that they can hold and chew are excellent for that. External jaw and lip support we talked about, and extrasensory feedback. So if you can't feel what's going on in your mouth, it's almost impossible to control it. And some children with CP have inhibited sensation. And so if they can't feel the food, even more difficult to control and create a cohesive bolus. So increasing the crunch of food, changing the temperature so that it's warm or cold, or heightening the flavour with pepper or salt or lemon or chili or spices can increase that sensory feedback in their mouth and make it easier for them. Also, if you're doing drinking and you have access to carbonated drinks like a mineral water or soda water or even lemonade sometimes, from time to time, that bubbly, effervescent from soft drinks can also help to increase that sensory feedback in their mouth. But again, with all of these, use them from time to time. If you don't have to use them, or you can do without them, or you can start to reduce them, we want to be able to do that because we're modifying the task with compensations and they need to have opportunity to practice the whole real task. These are some indirect interventions. So as we said, we don't want to be doing these unless we absolutely have to. So these are for children who are totally tube fed and are not safe to have foods. If they're safe to have foods or they're safe to have some drinks, then we can use indirect interventions. If they're safe to have any food or drink, then we want to be using direct interventions and compensations. If they're not and they're nil by mouth, because they're too high risk of aspiration, that's when these can come into play as well. So sucking on a dummy or a pacifier for babies, if you can dip that dummy in milk, you're stimulating some of that, the swallowing and the sucking action with real drink and with real food. So that is starting to transition to a direct intervention. So dummy dipping is great. Biting on silicone tubes, like we mentioned, can improve some strength in their jaw, but often strength is not the issue. If they can handle real food, you can do some of that chewing practice on firm foods. The head lift, which is called the Shakir exercise, is one that primarily for adults you need to have quite good cognition and be able to follow instructions for the head lift or the Masako maneuver. There's another one called the effortful swallow. But these are all interventions primarily for adults who've had a stroke. That's where most of the research is for those. So direct interventions, this is what we want to do. Actually, I want to show you. Yeah, okay. So start with the IDSI level, that is the highest level that they're safe for 3 to 5 mouthfuls. If they're safe at 3 to 5 mouthfuls, that's a great opportunity for practicing. You can practice during snack times, at the start of meal times with those harder foods, and then move to some of the easier foods or use more compensations as the meal progresses. Snack times are great because most kids don't tend to eat very much during snack times. And so they're not eating very much. It's not about nutrition consumption. They can practice some of these. And if they don't have very much, it's not a big deal from a nutritional standpoint. And then all of the compensations that you need to make mealtime, the main meals, more efficient, you can use at a separate time. Slowly increasing the size of mouthfuls. So if we are trying to practice with thin fluids, for example, you might give them a tiny, tiny little sip of drink. But then as they get better at that skill, you want to increase the size of the fluid sips that they're having. So you might go from 1 milliliter to 2 to 3 to 5. And over several weeks, say 2 weeks of practicing 1 milliliter several times a day. And then next week you might practice 2 milliliters. So starting to increase that size. Increasing the timing of mouthfuls. So we talked about with compensations that we want to give them extra time. So starting to prompt them to eat a little bit faster or offering another mouthful can sometimes prompt them to swallow and be ready for the next mouthful. Practicing those difficult textures during the snacks 3 times a day is ideal. If they can practice for 15 minutes 3 times a day, then they will get 60 hours of practice in 3 months. And that's where all of the research says if we want to change the brain, if we want to work on neuroplasticity, 60 hours of practice is our sweet spot. Progressive overload, so moving to the next level of food or drink when they can safely manage about 8 to 10 mouthfuls. So you're working in those short snack times. If they can manage 8 to 10 mouthfuls, start introducing that same difficult, challenging food or drink during those meal times. And then mix it up. Once you've transferred to the meal times, do it in different locations. Alternate mouthfuls of soft food with a puree, with a chewable food, so they're getting lots of different levels of stimulation once they can do it well at 8 to 10 mouthfuls. So this is a bit of a hierarchy of how to increase the challenge with food and drink. So start with just a couple of mouthfuls, small slices, and start to increase the difficulty and generalize to meal times over time. So if you're wanting to transition to chewable foods, starting at 6 months, this is what you need. 6 to 10 months is where you need to be. So you can see this mum is putting the food to the side of the mouth here. That's another lovely practice. If they're having trouble with chewing, if they're doing the up-down chewing motion, lateral placement is your best friend. You want to be able to get the child seated, upright, in flexion for about 20 to 30 minutes. If they can only do it for short periods of time, that's fine. Just keep the meal time or snack time really short at first, and then over time increase. And then we want that child to be looking at food, interested in food when they are ready for solids. So these are for some of the cues that you might look for babies at that 6-month age, around 6 months when they're ready to transition from milk to solids. If they're bringing toys to their mouth, that's such an important skill to look for. A lot of our children with CP can't grasp, hold, and bring toys to their mouth. And so what happens is they lose some of those early opportunities of building the skills in their mouth to be able to chew on for foods. The other thing that it does when typically developing babies bring food and toys in their hands to their mouth is it moves that gag reflex trigger point from the front of our mouth to the back. So when babies in the first 6 months of life have a gag reflex that triggers right at the tip of their tongue, and that stops anything but milk going in their mouth. When they're starting to prepare for introduction of solids, that's when the toys normally come to their mouth. That repeated exposure of bringing things in their mouth helps to desensitize or move that trigger point of the gag reflex from the tip of their tongue further back in their mouth. And so a lot of our children with CP will see gag because they haven't had that early exposure of putting things in their mouth because of their fine motor skills. And it makes gagging much more prevalent. So how can we offer foods to these children? We want them to be in control. All of the research says when somebody feeds themselves, the risk of choking, the risk of aspiration is much lower. So independent feeding is where we want to try to aim for. So putting foods on their tray that they can grasp with some extra support from us. And bringing that food to their mouth. Kids will often tend to automatically put food in the side of their mouth rather than the middle of their mouth as well. Modelling, so if we're sitting in front of them, we're eating the same foods. Children learn so much from watching us eat. That modelling is really, really important. So family meal times are excellent. We talked about putting food laterally. And we want to aim to progress from smooth purees to minced and moist in about 4 to 8 weeks for these young babies. So if you're introducing purees at 6 months, within a couple of months, you want to be starting to introduce some of these chewable foods. And then those dissolvable foods that we often see, like biscuits, crackers, they're great after 8 weeks. And they're also those transitional foods. Then minced and moist or mashed foods, then dissolvable or transitional foods, then hard munchable foods, so frozen foods. I'll show you some net feeding bags in a couple of slides, and some teething toys if you need to, or silicone chewy tubes if you need to, but dip them in puree to give them something to eat, some flavour there as well to stimulate that swallowing, and soft food. So again, this is the sort of progression that you want to move through. Open cup drinking we want to do from around 6 months of age. We want them to be in this flex position, nice small cup here. This is actually the lid of a baby's bottle. Normally they're quite flexible, so you can fit them to the child's mouth well. And you don't want to put the cup just on the tip of the child's mouth. You want to try and give them some extra tactile support. So you want to push the cup all the way into the corners of their mouth, like this. Bring the fluid right to the edge of the lip of the cup, and then let the child do the rest of the work themselves. So you can also do it with puree. If you're finding that the drink is just going everywhere and they need some extra time, thickening fluids, offering some yogurt or puree from a cup can help to give them some extra time to learn how to do that cup drinking or even straw drinking. Dipping the straw in some puree is a great way to introduce that too. But again, move on very quickly. You don't want to stay there. You don't want to do all of the extra work or make it too easy for the child. You want to find the just right challenge, not too hard, not too easy. So we talked about fill to the top, wait for that child to create the lip seal. You can give them some extra support if you need to. And some environmental changes that you can make. Nice, calm environment. We spoke about fight or flight, where your body switches off your hunger. You want to avoid that. We want the child to be interested and motivated. So giving them foods that they enjoy when you're working on a hard skill is great. We only want to be doing one hard thing at a time. So we don't want to try and teach them how to eat a food that they don't like, while also work on that skill building. Make it fun, make it enjoyable. Minimize distractions around. If you can avoid having a TV or a screen around, that's great. Sometimes you need it. But what happens when a screen or distraction is around is the child is focusing on that. And so their ability to learn the task that they're doing is less because their cognitive load is split between two different tasks. pleasant environment, make it enjoyable, and get them to eating with you and with their family as well. Communication, so important. I'm a speech pathologist, so there's always going to be a communication aspect in it in meal times, and we know that that social aspect to meal times is so, so important. So if they're a non-verbal child, if they're non-speaking, give them some choice and control. Hold up 2 different foods. Get them to tell you by reaching or looking at the food that they want to start off with. If they have a communication system or access to an eye gaze device or an iPad or even just pictures, get them to use that during their meal times to choose food, to tell you when they want more, to tell you when they need a break, to tell you when they want to stop and they're finished. These are all so important for not just the social aspect, but also the safety of meal times. Sometimes feeding tubes will be necessary. It's not available in all settings, particularly if you have issues with sanitation and water supply. But sometimes feeding tubes can be necessary and a lifesaver for a lot of nutrition. We still want a lot of these children to be able to eat orally at some point. To practice that skill, remember, use it or lose it. And use it and improve it, but it can be really helpful if you have access to it. The other thing is oral hygiene. So this is very important. We talked about aspiration pneumonia or chest infections developing if the child aspirates or food or fluid goes down the wrong way and takes bacteria along with it. And that bacteria comes from inside their mouth, particularly if they're not eating and drinking very much. If you think about an ocean versus a pond that doesn't move, the ocean has lots of flow of motion within it, and the buildup of bacteria and the smell doesn't happen anywhere near as much as a pond that has stagnant water that's not moving. So if a child's not eating very often or nil by mouth, same goes for adults, their oral hygiene is going to be even more important. If they're at risk of aspiration, again, their hygiene is so, so important because we want to reduce the bacteria in their mouth. I'm going to, do we have the video? Our video is not working. Give me a second, I might be able to find it. Yes, okay. So I'll share this video with you to help give you some guidance around how to brush someone's teeth who has a disability. This is just from YouTube, so you can find it on YouTube as well.
Amanda, we can't hear the sound.
Okay. It's got captions up there, that should be fine.
Yeah. All right, okay.
So doing toothbrushing and oral care after meal times will help to make sure there's no residue left over in their mouth after the meal time that can also increase risk of aspiration. Positioning is very important here. Same upright, stable positioning. If they're a person who has a lot of trouble with positioning and with saliva control, you can clean their teeth in prone, like we were talking about earlier as well. I'll just talk to more about that after this. So oral hygiene is very, very important. So I was going to go through prone for oral care. So for a child who has trouble managing their saliva, prone positioning can be really helpful. If they have a wedge or a pillow that you can put under them, I'll see if I can try and recreate this for you. My doll. I might just stop sharing my screen for a second because I think that will make my video bigger for you so you can see. But if you have a cushion, you can get them to rest their chest on. Have them lie in prone. You want to try and encourage as much flexion as possible. So if you can get flexion in their knees, great. If you can get their arms up, excellent. And then this helps with their head control. And you can do the oral care this way. So if you're sitting in front of the child, they're in this prone position. And then what this does, if they are at high risk of aspiration, when they're in prone, it encourages all of that excess saliva, all of the toothpaste to come out the front of their mouth rather than posteriorly, and which can then go into their airways. So the children who are at high risk of aspiration, who are nil by mouth, trying to do oral cares in prone can be really helpful. Okay. Okay, so things that we were trying to look out for: if they're coughing, a change in breathing, their poor lip seal, food or drink falling out of their mouth. So if they're coughing, it's telling you that there's a risk of aspiration. You need to make the task easier. Use more compensation strategies. If you notice a change in their breathing, stop the meal, give them more time, let them recover, and then try again. If they have a poor lip seal, you can do the external jaw support and lip support. If they have food or drink falling out of their mouth, you can do the same thing. If there's any residue in their mouth, you can prompt them to close their mouth by tapping their lips, tap their chin, or give them an empty, clean spoon to help prompt them to swallow again. If they're fatiguing, falling asleep, stop the meal and try and work out why. The task was probably too hard, or it was going on for too long. You don't want meal times to go on for more than 30 minutes because that's when they start to fatigue and burn the calories that they're consuming. So if the amount that they're going to be eating after 30 minutes is going to be very minimal, and it will be harder for them because they've expended all of their energy and they're fatigued and tired. So they'll start to burn more energy at that point. And the balance of calorie intake versus calorie expenditure will end up being equal. To stop the meal, probably make it easier next time by using more compensations, or make meal times shorter and more frequent. If they're crying before, during, or after feed, there's a reason why. Children will eat if they can, and it's our job to try and figure out why. Do they have reflux and they're uncomfortable? Are they at risk of aspiration? Are there other gastrointestinal issues? Is it a hard task, too stressful for them? You need to try and work those things out and use the right interventions to help. If their growth is faltering, if you have access to a dietitian, they are invaluable. Trying to increase the calorie concentration in their food is a strategy you can use, but also making the task easier. They're going to eat more if the meal is pureed versus something that needs a lot of chewing. So you might want to use pureed foods for main meals, and then snack times can be those food challenges that are more difficult. They're refusing, again, go back to trying to figure out why, make the mealtime more enjoyable and less stressful for them, and easier if you need to. Meal times are long, likely to be a reason for that as well. Keep it shorter. And if there's still lots of food left over, it's likely that the consistency of the food is too difficult. The same if they're not finishing the meal. If they're stressed, figure out why. Force feeding will end up creating more issues for you down the track, and increase their risk of aspiration. If they're feeding themselves, they know when they're ready for the next mouthful. They know if there's residue left over. They know if they need to slow down. They know if they need more time. We can't judge that as somebody who's helping them. So much better off. Was there a question? So sorry, someone's just unmuted themselves.
No, sorry, Amanda, I'm just, no questions so far. Please go ahead.
Right. And I know there can be family pressure sometimes from the extended family, but it's important for you to pass on some of the messages to a lot of the extended family who are supporting them. They can come into your sessions. If the parents can then pass on the messages that this is what we're going to do, this is what the speech pathologist or the physio or the OT or the whoever has told them that we need to try, and why, that can make families understand it a little bit better. If you're noticing increased tone during meal times, it's normally a stress cue. Extension as well, another stress cue that you might notice, or they're not inflection enough. If you're noticing lots of movements, if they're dyskinetic or if they have dystonia or athetosis, you can normally reduce some of those excessive movements by having them inflection and well supported. Same for some of these primitive reflexes that are still there. So for the startle reflex, if they're inflection, you'll see a reduction in these. The startle reflex, if there's distraction around, you might see that, so reducing distraction. Bite reflex, sometimes if you put food or spoons to their teeth, they might have a bite reflex and bite down. If they do, don't pull on the spoon. This will just make them bite down more firmly. You can massage their temporomandibular joint, which will help release it, or say something that will make them smile or laugh. That will help release it as well. You can reduce that risk by putting the spoon in the midline of their mouth, or food in the middle of their mouth, if it's a spoon in particular, and push down in the middle of their tongue, and then remove the spoon quickly. So in, push down, remove the spoon. That can help reduce the bite reflex kicking in. ATNR reflex will often see if the person feeding them is on their side and they're turning to them, you'll see the arm go out, the leg go up. So feeding them from the midline is your best option, and at the same eye level as them. If they have an active seizure, stop feeding them. Make sure that they see a neurologist and they're getting medication to try and, or a management plan for their seizures. But if they are having a seizure during a mealtime, put them in the recovery position on their side or in prone, particularly if they have any food in their mouth. If you can, try and get the food out, but don't be putting your finger into their mouth. Only do that if it is right at the front of their mouth. Medications, if they have to have medications, you want to try and make them the same consistency as the food that is safest for them. So if you can crush the tablets, great, mix it with a puree. Normally a puree that's not dairy based is a better option because sometimes the dairy can break down some medications. If you have access to a pharmacist that can modify the consistency to a liquid and a thicker liquid, that would be ideal. If you have to give it from a syringe, you can, but do it in their cheek pocket. Put the syringe in their buccal cavity and as far back as you possibly can. If they have reflux.
Oye, Alexia,
Oh, Mariana.
¿tiene hambre ya? ¿No?
Mute your...
¿Les preguntas para ver si vamos a comer allá? Porque lo sé.
Thank you. Reflux, if they have access to medication, that can help a lot. Small, frequent meals can also be really helpful. Reducing, if they're on milk, sometimes adding thickener to their milk to make it slightly thick can help keep it down because it's denser. A lot of children do better when they're on solids as opposed to liquids. So if they're on a liquid diet, you might see more. And keeping them upright. We spoke about upright positioning. If they're lying down, it's much more risk that the food will come back up from their stomach into their esophagus and then airways, and that can put them at risk of aspiration. So upright positioning for meal times and for about half an hour after meals. If they're vomiting, they might have an allergy or an intolerance, so you please see their doctor. If they're constipated, they might not be getting enough fluid, or they might have an allergy or intolerance. Again, see their doctor to help with that. You can try and increase their fluid intake by adding extra fluid into their puree and their foods. That can help too. And if they're having trouble with their head control, positioning, inflection, using some extra towels around their neck like we showed you. If they're having some fine motor control issues. Oh, there was a picture that I was hoping to show that doesn't seem to be in here. But if they're having fine motor control issues and they're having trouble bringing their hand to their mouth, often we'll take their wrist and do it for them. But again, we want them to be as independent as possible. So helping them from the elbow to lift their arm up like this, and then they can do the rest of the task themselves. If they're having trouble holding onto a spoon, making it thicker. What we did with one of the children in Bangladesh was wrap tissue or toilet paper, actually, we used around the handle of the spoon to make it nice and chunky. If it's chunky, it's much easier to grasp than something that is thin. So make it chunkier, give them support from the elbow, not the wrist, and encourage as much self-feeding as you can. And that's it. That went much longer than I thought.
No, it has been an amazing session. Oh my God, Amanda, thank you so much.
Hopefully
everyone, please feel free to ask questions. It's like
yes.
a very, very informative session, Amanda.
I think
I do have a, sorry, yes, please go ahead, Mama.
I think Farhan has sent a big list of questions. I mean, 5 or 6. Yeah.
You can just, if also you can email me, Farhan, or anybody else, but I'm happy to answer a couple of questions. I'll just put my email address up on the screen as well, so you've got that if you want to email me. But yeah, Mahmoud, if you want to ask 1 or 2 of those questions, I'm happy to answer them.
Okay, the first question is: child whose both lips remain open, cannot sip liquid, even cannot perform straw drinking in age of 2 years. What can be done?
Yeah, so we're talking about that the jaw support, that lip support. Their top lip doesn't need to do very much. if the mandible is up and the jaw is closed, and you're able to create that lip seal much better with the lower lip, and then the top lip doesn't have to do very much. The same you can do for a straw, same jaw support and lip support is what you want to try and aim for.
Okay. The second question is why child vomiting after taking any foods or specific foods like eggs or fish? Is vomiting
So that could be an allergy. Yeah, it could be an allergy or an intolerance. Egg and fish are common allergen foods, so definitely see their doctor or dietitian, and they can do further testing. There's no particular reason. You could try to see if it's a consistency, that they're gagging on that particular consistency of food by pureeing it. But if they're still vomiting, particularly if it's after the meal, then it's likely to be an allergy or an intolerance. So definitely see the doctor. You can try to see, try an elimination diet to see if they don't offer those foods, whether they react the same way.
Okay, thank you. Don't see any further questions.
Yeah, there was another question, Mahmoud, on chat box from Shihab, I think.
Yeah.
Positioning regarding the dystonic CP is tough for him. Anything you could share? Positioning a child with dystonic CP?
Yeah, so I mentioned that just at the end. So if they are dystonic, positioning them very snugly in flexion can help to reduce some of those excessive movements. Sometimes it is still very difficult, and you want to try and develop a consistent motor plan. So every time you offer the food, you need to be in the same position, the child needs to be in the same position, and you offer the food in the same spot in midline, close to their lips. And then they don't have to do a lot of extra movement to be able to get that food. If you're minimizing the active movement that they have to do, and that will end up reducing some of those uncontrolled movements. Also, reducing distraction in the environment can help as well. But positioning of the child and positioning of the food and yourself will help somewhat. But sometimes there's nothing that you that will reduce all of the excessive movements. Are there any other questions?
Two compliments, one from Susan Smith, another from Laura. Thank you very much. Very informative for a dietitian to hear your lecture.
No worries, my pleasure.
Great. Amanda, we still have 28 people online, and I know that at some point we had almost 50 people joining. So you can imagine the need for this webinar, and thank you so much. So this session will be uploaded on GLM CPR's YouTube channel. So please feel free to subscribe, and we will also send you an email with the link once it's uploaded. You have Amanda's email address if you want to reach out, and of course, you also have GLM CPR's email address. Please let us know if you need any information, resources, and any other assistance in this regard. If no one else has any question, then we would like to conclude this session with a big thank to Amanda. Thank you so much. It has been really helpful.
My pleasure.
Okay. Before closing, we usually take a screenshot of everyone's, like all the participants, if possible, and if you would like to, turn on your video camera and we can just take a photo, if that's okay. All right. Camera's turning on. Come on, everyone, don't feel shy.
Please turn it.
It's starting, yeah. Nice. Okay, I will start one now, and then we will take a few shots if that's okay.
Nice to see everyone's face.
All right. Ready? 1, 2, 3, go.
Lovely.
Another one, please. Just give me a minute. There were a few people not on the screen. Okay. 1, 2, 3, go.
My cheeks are getting sore from all the smiling.
No, I think we are good. Thank you so much. All right, everyone. Thank you, stay well, and enjoy the weekend. Amanda, thank you so much again. See you soon.
My pleasure.
Thank you.
Thank you,
Bye.
everyone. Bye-bye.
Bye. Bye.